Good afternoon, everybody. Welcome to today's talk on dietary and lifestyle modification for urinary stone. My name is Dr. J. Lim from Pan Asia Surgery. I would like to thank Sam for agreeing to be the chairperson and the kind introduction that he had. I was previously from Singapore General Hospital. I'm currently with Pan Asia since middle of March. My subspecialty is in the field of endourology, which is basically dealing with urinary stone stuff. I've seen also move on to laparoscopic and robotic and general urology. Today's talk is going to be about my favorite topic, which is on urinary stones, and I have decided to keep it to the basic facts on this topic, which is very usually glossed over. We see many of urinary stones cases, particularly the asymptomatic ones in our practice. Regardless of what you practice in, you will invariably see some of these cases and might get asked as to what do we do in terms of preventing stones on the dietary and the lifestyle aspect. So that's why I've basically tailored today's talk to be packaged in such a way that is very much distilled into bite-sized pieces that we can hopefully bring back and depart these knowledge to our patients as soon as after this session. So I'm going to cover a few topics for today. We will start off with a brief introduction of the prevalence and the incidence of stone diseases, and we jump straight into diet and lifestyle of the main topic, and from there on we will distill small bite-sized take-home messages that you can take home and use it immediately in your clinical practice. If we have time, we will basically also talk a bit about the latest in stone surgery, particularly in the field of lasers, because invariably you might have heard words like holmium and thulium that you being thrown around by urologists, which you may or may not be familiar with. So I would attempt to basically give everybody a brief introduction into what these terms really means. So let's get straight into today's topic, which is stone. So the incidence of this condition is fairly high. It's been around for the last 3 to 5,000 years. It's been documented in the earliest of stone inscription in ancient Egypt. The incidence in modern day is as high as 19% in men and 9% women, and these numbers comes from in the Japan region, a Japanese study, and that's because we live in a stone belt. Now, this stone belt basically is the middle span of the globe, whereby there is a higher incidence of stone disease, and this is due to the combination of the climates and the diet that we take. The stone belt extends from the northern part of Australia, and it spans across the archipelago Indonesia, going into Indochina, Southeast Asia, subcontinent India continent, go to Middle East, and the top part of northern continent Africa, southern part of continental Europe, crosses the Atlantic and goes straight into America. The figures can be as high as 20% in Japan and 49% in Saudi Arabia men, and then you drop to the low teens in continental America. And there is a huge variability, probably due to the lack of good quality studies. As we all know, in our respective discipline, a lot of studies are mainly done in Northern America continent and Europe, and so not so much good quality large population based studies that can be done in Central Asia, Middle East and Africa, and even in some part of Asia as well. Most of the stones that we see are calcium oxalate, and so we will be covering a bit about calcium oxalate and what role do they play in the role of prevention. As we've always said, once a stone former, always a stone former. If you have an episode of stones, it's very likely eventually that you will be having another stone attack. So it's very important to find out what can you do to prevent it from coming back as best as you can. So as I previously alluded, we will invariably see stone patients in our clinical practice. A lot of them basically comes as asymptomatic stones, and they might pop the question, so doc, I have a stone in my kidney, so what do I do about it? Doesn't really bother me, but will it bother me sometime? Gowacki basically did a landmark study in 1992 that was published in the Journal of Urology, and we've always quoted that during exam. That is, stones invariably will do something. They either grow bigger, they either shift, or they either basically scratch you and cause you to bleed. Some form of symptoms one way or the other. Pain being the most significant, but there are others as well, including recurrent urinary tract infection or blood in your urine. The percentage of the episodes that can cause a problem can be as high as 40%. And as the stone gets bigger, they either shift or move or cause pain. You may need to intervene, and the risk of getting intervention increases up to 25% annually. So for the worst sufferers of stone disease, you potentially would require surgery every 1 in 4 years. Now, adding all in all together, Gowacki calculated that the 5-year risk of something happening to a asymptomatic stone is around the range of 50%. The first take-home message, essentially what I always tell my patient is basically to flip a coin and see which side do you land on, and you really want to try your best to be on the side that doesn't come back to see me within the next 5 years. There is, however, a later data that has been quoted in the European guidelines that actually says the more accurate number of a 5-year event probability is closer to the range of 25, which is still quite significant. That is to say, 1 in 4 patients, if you have a stone, something will happen in the next 5 years in a quarter of them. What can we do in this case? At the crux of the matter, stone prevention is really about balance. And you will hear me talking about the word balance many times during this lecture. It really is a battle between good versus evil, in this case promoter versus inhibitors. There is a fixed methodology or fixed epidemiology, there is a fixed pathogenesis of how stone is formed. You must have the necessary ingredients in the urine environment, coupled with certain conditions like dehydration, more calcium or more oxalate in the urine, supersaturation occurs, small urine crystals come by, and they grow bigger and bigger and blah, 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 blah. So we will not go through that. The goal is really to try to balance or tip the favor towards the inhibitors, so much so that stones are not formed so easily. What do we do about that? Broadly classify, I'll spread them up into dietary and lifestyle. What can we do in the dietary department of things that we can actually bring home and tell our patients? This slide is probably the single most important slide that you're going to hear from me today, and that is water, 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 or fluid, fluid, fluid. This is the single most important thing that we can impart. This piece of knowledge is probably the most important advice that we can give to our patients starting at 2 p.m. today. However, it's not just a piece of general advice that you hear about drinking, benefits of drinking water, which our mom has always told us, but we never believe for the last 40 years that we've been around, or 50 years that we've been around. You've got to package it in such a way that it's actually usable and not just be another piece of general advice. So we will try to go through that in a bit. But suffice to say, the scientific evidence behind this fluid is irrefutable. The Europeans in their latest 2023 guidelines have said it so, and Americans in their 19 guidelines. And they basically even tell you to go for a volume of more than 2.5 liters of fluid, preferably neutral pH fluid, but that is indeed a very large amount to drink. So I don't actually take this whole piece of advice lock, stock and barrel, and I generally modulate a bit about that. If you tell patients to go drink, most of them will say, oh yeah, sure, I will. But they have no idea about how to go about doing it. A quick and simple test is basically what I do with my patient is to ask them how much they drink, or 1.2 liters, 2 liters, 6 to 8 cups a day. Then I basically hold on to my own water bottles that I have in the clinic. I always have one, and I ask them to make an estimation of how much that bottle is. And in most times, you will find that patients or humans in general are very bad at predicting water volume. We are bad at predicting how much we drink, and we are even worse at predicting how much we actually void. We simply have no idea or are very far from the truth. So instead of just telling them generic information like drink a lot of water, what I basically go and do is I basically tell them to take their favorite water bottle, and that could be the size of those little small little cute ones that ladies have in their bags, or the big ass ones that the young guys use as a dumbbell in their free time. Whatever their flavor is basically get them to measure that cup and figure out how many bottles do they have to top it up in a single day to hit 1.5 or 2 liters. Now, I also don't follow strictly the amount of water that you need to drink. The Angmo's tell you is 2.5, but we know that in the local population, getting someone to drink 2 liters is already a struggle. At the end of the day, what the guidelines was trying to do is actually to get around the range of a 1.5 liter urine of output, and that amount, study shows, has probably been the best range that is neither overly excessive or under drinking. 1.5 liters is probably the ballpark figure of how we got around and what we're trying to achieve. So instead of telling patients to drink 2.5 liters, which really no one will follow your advice, there's no point giving advice that's not going to work. So really, instead I tell them to take 1.5 liters of fluid, and using their bottles, they figure out how many bottles they need to top out in a day, and then they add the rest with insatiable intake, like in your noodle soup or in the rice, which contains minute amounts of moisture, but certainly they are there. And I find that that's been a lot more receptive to most, especially older ladies. It is also important to tell them, on top of the fluid advice, when to drink it. Many smart aleck patients that I have basically say, oh great, sure, no problem, Jay. I will then scour 1 liter or 2 big dumbbell size liter of water the moment I wake up, and I'll carry on my day. Or I said to them, nah, that's not going to work, bro. They then tell me, sure, great, I'll spread it out then. I've got to spread it out, sure. 1 liter in the morning, 1 liter at night. Now, unless you're a camel and you have a reservoir in a hump, that's not how the body works. Excessive amount of fluids taken in a quick short period of time simply get pushed out, and they go into this relative state of dehydration. And particularly with the challenging climate that we have, they end up losing more, especially when they are at a time where they are ill pressed and they are already dehydrated. So it's important to tailor the drinking advice to circadian rhythm too. What do I mean? You don't go around telling patients to drink in the front part where everybody goes in, because you simply just pee it out. Neither do you do it at the later part, because what happens at the later part, although it's a lot more absorbed by the body, when you tell people to drink after they knock off from work, what they tend to do is that they overly do it. And if you have someone to drink a lot of fluid at around 8 or 9 after dinner, what happens in 3 hours time when the fluid goes from one end of the head to the other end of the other head is that they start peeing just about the time that they go to sleep, which is not too bad, or 1 or 2 hours after they sleep. And if you have older males in these populations, they basically worsen their LUTS symptoms, nocturial symptoms, and you end up getting a very unhappy patient. So all in all, hydration advice is important, but 2 pieces of advice, which is to actually get a bottle that you can actually tell your patients how much they actually do drink and the timing of which it happens. At the end of the day, if all fails, you ask patients to look at the urine color. And I've always have this chart handy somewhere on the desktop or my computer or printed on the wall. Is we generally try to aim the left half of the picture, which is the good fair, and it's not realistic to get the very good. And if everybody consistently tell you very, very good, they're always very, very good, then something is very wrong. Either they are lying or they're colorblind. you definitely don't want to be on the other side of the spectrum, simply because in a climate like Singapore, you are basically really asking for trouble. Now we move on to the role of caffeine. This is fairly controversial in the field of stone formation. First, we thought it didn't cause more stone. Then we thought that it caused more stone. Now I think we're moving back towards that it doesn't cause much stone formation. It is one of the most popular drink in the world. I am a victim. I would guilty as such. And they are essentially very ubiquitous everywhere in the world, and a lot of people drink them because it perks up the day and they need to start in the day, like a lot of us here in this forum. Caffeine works on the distal nephrons. The end result is that it dilutes the urine, but because calcium follows the volume and sodium and fluid, it actually increases calcium in the urinary system. When that happens, you get a hypercalciuria state. I'm gonna get you to hold on to that thought for a while. That calcium in the urine. Okay, just hold on to that thought. You must have calcium, but it should not come out in the urine. I'll come back to this point in the next following slides. Now, the latest studies from Europe has shown that out of with a population studies of around 190,000 population, they actually found that coffee, tea, beer, orange, and even wine don't cause more stones compared to sweetened drinks or liquefied carbonated high sugar fluid. There was no third arm that compared it with neutral pH fluid, so we would never know, and we cannot conclusively conclude that caffeine is protective of stone formation when compared to fluid. But certainly they found that sweet drinks is worse. If anything, that's the take-home message that I got, that sweet drinks is actually worse than coffee or caffeine when it comes to stone formation. And always remember that caffeine is a diuresis. You get a relative dehydration, particularly if you don't drink enough, plus the fact that it causes urgency. And when you pack that in the morning in a state of the relative dehydration, generally it's going to worsen the urinary system, and you will basically hear a lot from your patients. And you might want to explore the caffeine intake of your patients if you do feel that there's a need to it. So caffeine, it's a bit of a controversial hit and miss down there. Generally, everything needs to be in balance is probably the best advice that I have for you. So we move on to the next two slides. We will cover calcium and the oxalate in the role of urinary stone formation. Now, why calcium oxalate? Because 70% of the stones that we get from urologists in the kidney are formed from calcium and oxalate. So the science behind it naturally went towards finding out whether we can take away all of this from our diet. If we don't have it in, then essentially we will not have it out. But as we all know, we need calcium for whatever purpose in the heart, in the musculoskeletal systems. So it's not something that we can safely take it out of our systems and not have any sequelae. And the science behind it is fairly clear. There is nothing to actually state that having a high diet of calcium concentration in your food equals to more stone. Why? Because as long as calcium is absorbed but excreted via the gut, is actually a good thing. The problem comes in when calcium is not absorbed in the gut, goes into the bloodstream, comes out via the kidney in the pee. Then we have a problem. So it's actually good in the gut, but poor in the pee. The reason for that is because calcium basically naturally looks for oxalate in the gut when they are being eaten at the same time, and they bind together irreversibly to form a poorly soluble compound. Because it's in the gut, everything is passed out fecally. If there is a disbalance between calcium and oxalate in the gut, they somehow get into the bloodstream. For example, there is not enough oxalate during mealtime, calcium goes into the bloodstream. Or if there's excessive oxalate outside of meal times, like snacks, then it goes into the bloodstream. both of them get excreted out because they are not binded in the blood vessels, and they go into the urine. That's where we have a problem. So no, trying to stop calcium in your diet is certainly not helpful. Or as long as we keep to the daily recommended dose of 1,000 milligrams to 1.2 milligrams, 1,200 milligrams a day, we are okay. Naturally, there will always be people that overdose on their supplements, or many kinds of supplements in the day, and you might be worthwhile to look at what they are taking. And 20% of the population have shown that you are more likely to form stones if you take supplements. So that is a food for thought. Another thing to remember is, apart from the calcium supplements that we hear a lot, are the vitamin C. Vitamin C is ascorbic acid, and note that, like the chemical pathway which I've seen returned back to my biochemistry teacher, is that it eventually gets converted to oxalate as well. And if you overtake those two on top of the calcium, if you keep it balanced within the recommended range, you're probably okay. But if you take any excessive of any one of those, we're going to get into trouble. So with that, we lead into oxalate. So what do we know about the oxalate? And oxalate is basically a big topic among the dietitian, because there are so much food out there that contains oxalate. You cannot possibly avoid everything that has a high oxalate content. And on top of that, you want to avoid calcium, and you're pretty much left with nothing except plain water. And oxalate does exist in a fair bit of amount in a lot of the snacks that we like. There is a comprehensive, it's a fairly comprehensive list in Harvard.edu website that tells you the concentration of the oxalate files, and if you're interested, you can have a look at it. But really, I don't think it's really helpful to sit around in your busy clinic talking to patients, looking at each of the food charts that you can find on the internet and figure out what is what. So as per what I previously said, in broad strokes, what you should do is, because oxalate does have its role in the body, and it actually promotes binding of the calcium within the GI tract, you don't actually want to tell people not to take any of those stuff. Instead, just go with a balanced diet with the food triangle that we all know: 3 portions of vegetables, 2 portions of dietary, 1 portion of meat. And generally that is actually good enough. There is no evidence out there to say that taking oxalate out of your body, except for a small population of patients who have malabsorptive stuff, basically there's no benefit at all. And to take oxalate during mealtime, because as I've said, when it meets calcium in the gut at the mealtime, everything gets binded in the GI tract, which is a good thing. What you shouldn't do is excessive vitamin C supplementation over excessive probiotics. What you shouldn't do is snack. And when we talk about snacks, it's one of those bad habits of mine, because I'm guilty as charged, because we all like our nuts and our ikan bilis and our pickled stuff and sweet and sour fried stuff. They basically have full of oxalate in them, and if you're taking it without a good balance of calcium in the system at the right time, they end up going into the vascular system and out in the kidney, and then you get an hyperoxalate urea state, which is not good. If you have malabsorption stemming from a previous surgery, shortcut syndrome, these are separate kettle of fish. Probably you will need to take a bit more care in avoiding excessive calcium and oxalate because of the short amount of gut available to do binding. These group of patients will need a bit more care, as they already do, so they would probably not be the one that you want to talk about oxalate. And if you do need to, you might want to seek some help from a dietitian or our GI colleagues on this topic. I've talked a lot about what to avoid, so I would need to then add in, or rather add on to, things that actually can help prevent or are good for the prevention of stone. And citric acid is one of those things that cannot be underestimated. The studies has very clearly shown that most stone formers, or rather 60% of stone formers, actually don't have enough citric in their urine. And what the role of citric does is that it actually helps bind calcium in the urinary system that prevents supersaturation and crystal matrix formation. And the other thing that it does is that for calcium oxalate compounds that are actually already formed in the urinary system, it actually prevents, it binds to them and prevents them from growing into large crystals, which is the basis of stone formation. So its role cannot be underestimated. Citric acid is fairly widely available in high concentrations in these drinks, as per picture shows. A lot of the citrus fruits, the lime juice, the orange juice, the mango juice, the yuzu drink that you want, and even probably a bit of those packet drinks that we are familiar with. And the recommendations are that you take about 120 mils per day, and really no one really goes around measuring how much is 120 mils a day. So what I've basically done is I'll measured it myself and worked it out that really is about 1 cup or 2 cups a week. So every other alternate days in a week, just pop in a bit of a sour stuff and you should be okay. And that's going to keep a healthy level of citric in your urinary system that prevents calcium oxalate stone formation. It's probably better than a lot of the things that we talked about in terms of trying to cut this off or cut that off from the diet. And rather than to do that, we just want to increase the fluid that we drink, and maybe just along with that a bit of citric acid in the choice of the beverage we drink. Apart from drinks, we move on to salt and the role of salt and animal protein in stone formation. How it works is that with high sodium, calcium follows in terms of the excretion, and it prevents citrate from all going out into the renal system, all right, and the proximal tubules. And what happens is that the net output is that you go into the hyper calciuric state and a low hypo-citric urea state of things. And when that happens, stone formation occurs. And many trials out there have shown that if you were to just push down the salt and you push down the low amount of animal proteins, just keep it a normal calcium diet, it's very good in preventing stone formation. Animal protein also causes lowering of urinary pH, increases the byproducts from processing animal proteins like purine. It causes hyperoxyuria and high amount of uric acid in the urinary system. The recommended dosage of animal proteins in a day to keep it in a healthy state is around 1 gram per kilogram. So you're looking at an 80 gram amount of average of animal proteins in an 80 kilogram guy. And again, what does that mean to the patient? It's roughly about the size of a deck of poker cards. Okay, just the normal size one, not the ones that you see in the fortune teller big ones. This is normal ones, and those are generally good enough, or they're equivalent to 3 slashes of bacon. If that's your poison, roughly it's a size of a quarter pounder, nothing more. Probably a bit too much in the quarter pounder, but generally about there, give and take a bit. And that's generally good enough advice when it comes to diet. Now, we move on to lifestyle and implications when it comes to stone formation. A lot of it is basically common sense, because if you live in Singapore long enough, you probably know the kind of weather that we have and how much we sweat. And particularly for those that we need to serve NS, life would be a lot more ideal if we can actually force everybody to have a water parade every 3 hourly, but that's not going to happen anytime soon. Climate definitely have an effect when it comes to stone formation. Obesity and the lack of exercise certainly has a role to play, and we'll go into that. So when it comes to lifestyle and drinking, remember the thing that the circadian rhythm, that you got to time to the circadian rhythm is important, and where possible you should be looking at pH neutral drinking. So climate has a role to play. Surprisingly, there's actually no direct evidence to link climate to stone formation. What we do know are indirect evidence. There was a study by an American military servicemen that look at this particular cohort of soldiers who were there first deployed in continental America and then basically moved forward to the Middle East in the 90s during the Middle Eastern War, and they found that the similar cohort of patients, the only thing that's changed is the climate, that they started forming more stones. And that's essentially the best kind of indirect evidence that we have, because the key reason as to why they think that's happened because it's the dehydration, and dehydration is directly related to climate. Okay, the kind of stones that we've also see is different between the climates that we have now. About 500 years ago, we generally were having a lot more bladder stones formed, and this you can see from the ancient medical texts. That's hypothesis is because of the fact that those days animal proteins were not easily available, and we had a high cereal diet, a high fiber diet. As a result of that, the chemical composition of our urine was a bit different, so much so that we didn't live long enough to have big prostate problems. We were dying, and the average lifespan was around 40 to 50 around 500 years ago. So we were seeing big bladder stones, but not so much ureteric stones. As we transit to a high animal protein diet, poor and better quality drinking water with a lower cereal content in our diet, we actually change the kind of stones that we were forming, so much so that we see smaller stones in the upper tract rather than the lower tract. And climate definitely has a role to play in that, because of the dehydration, lack of animal protein, or lack of poor drinking quality water had a role in forming stones. And these are the best indirect evidence that we can link climate to. But anecdotally, really it's a no-brainer because of the amount of sweat that we end up losing in a day. And in Singapore, I think everybody has, you don't need to be rocket scientist to figure out that the more sweat you lose during the day can have a direct impact on your urine concentration, and it fits in with all that we said. But surprisingly, just a matter of fact, we actually do not have a direct link with climate when it comes to stone formation. Obesity and how it plays. Now, unless you're a hippopotamus, most of the obesity that we see in humans is related to a high animal protein diet. And a high animal protein diet, we already established, works towards stone formation. The other thing that stones formations in high animal protein diets, it shifts the urine pH towards the acidic spectrum. Now, at that range, uric acid actually has a lot more role in forming stone. Because they eat more animal protein, they get more purine, and more purine is metabolized to uric acid. And if you add that to a low pH with a dehydrated state, uric acid stones forms a lot more in this situation, and that's a lot more easily formed than calcium oxalate. The good thing about uric acid stone naturally is because you can actually dissolve it. The other thing that they found in diet that could cause obesity, that could cause stone formation, especially in the obese cohort, is the role of fructose in the diet. So not glucose, but fructose. Fructose, they can see the NTHINGS database, which is the National Healthcare and Nutritional Assessment database. They found that the more dietary fructose you take, the more stones you form. The role exactly is not very clear for now, and there more work needs to be done. But certainly, the diet, the high animal protein, and fructose potentially in the obese population is a very high risk for stone formation. Something to take note in, okay, to keep looking at this. So with that, I'll probably come to the take-home message part of things, whereby I really want to then distill whatever we talked in the last 30 minutes to give you into usable take-home messages for your patients. And if you don't remember anything, it's just need to remember that everything needs to be a balance. There is no good in overdoing particular things when it comes to too much fluid too, over excessive supplementation, over prevention of certain things, too little animal proteins, too little calcium oxalate. It doesn't actually help anybody. But in summary, what I've summarized in my patients are always these few take-home points, because these are the ones that are the bang for buck. That is to try to go for a fluid around the range of a 2-liter mark, preferably neutral pH, so that you can generate around 1.5 liters. And I've given you a bit of a bandwidth to move around, because different habitus sometimes will require different more, and to always add citric acid into your fluid intake. The second piece of advice when it comes to dietary is aim for low animal protein. That's working around a size of the deck of a poker cards. And that's something that people can actually relate to better than, oh yeah, just cut down on animal proteins. What do you mean cut down? How much to cut down? Okay. Salt wise, the usual recommendation is 4 to 5 grams per day, and try to have a lot of fiber rich diet. A normal calcium, normal oxalate diet works well. And when it comes to lifestyle, avoid having obesity. You can do that through a adequate exercise, but when you do exercise, you've got to remember to top up with fluids, particularly if you're exercising in a hard environment. And always remember to look at the occupation of certain patients. They might require a bit more care when it comes to certain occupations, like bus drivers and pilots. These are high risk occupations that you really don't want any stones to be affecting them, especially when they're flying the plane that you are in on your way to a conference. And these 3 pieces of advice are probably as succinct as I can make them up to be. Fluid, lots of it, lots of it, lots of it, in a measurable manner. Citric acid, every alternate day, just a cup or half a cup. A deck of cards worth of meat. Don't go crazy about trying to cut things out from your diet. And when you should try to keep fit, not to be overly overweight, adequate exercise, and remember to replace the fluid loss. Are the kind of a summary advice that I hope everybody can remember and bring home and use it in our clinics later on this afternoon. I think I got a bit of a time left, around 3 to 5 minutes, so I'll very quickly go into a bit of an update when it comes to stone surgery. Now, what's really been happening in the last 10-20 years are essentially the role of newer lasers when it comes to hitting stones, and our lightsabers, and urologists like to play with fancy little toys, and I'm one of them, I have to admit. So we moved from a low power laser that we were using that gives only 20 watts of energy to the middle one that goes up to 100 and 150 watts, and the first two are basically based on holmium lasers. They're holmium type of lasers. Holmium as a crystal is used to generate the force, but as they got bigger, they got a lot more clunkier. And then in the last 5 to 7 years, thulium, which is another kind of element in the periodic table, started appearing on the horizon. The benefit of these lasers was such that they essentially did things faster and stronger and better and cheaper and everything else, and most importantly, they were smaller. The machines you see in the middle that you have, these take out a lot of energy, and they require those special plugs that you have to power air conditioner condensers unit, and they are 30 amp plugs. And the ones on your left or right hand side, thulium ones, you just retire the standard 13 amp 3-pin that we have. Apart from that, thulium got really into the pictures because as fibers shoot out from the fiber onto the stone, it goes through water as a medium. And with fluid, we then talk about what's the best medium to transfer energy instead of being lost, and warms out the water instead. The optimum bandwidth at which the optimal water absorption coefficient occurs at water is around the range of 1947 nanometers, which happens to be closest to the wavelength of the thulium light. Compared to the holmium, which is around the range of 2130 odd, it wasn't that good. A lot of energy was lost, heating up the fluid, burning the fiber itself, and as a result, you were shortening the fibers a lot with holmium, but not with thulium. Okay, And because thulium as an element is actually coated around the fiber itself to generate the kind of energy that comes out, it actually doesn't require physical shaking of the crystal. So they were able to actually come up with machines that were giving a higher frequency up to the range of 600 hertz of rotations per second when you use a thulium machine. That really is just a marketing gimmick, because the human hands can't really handle movements at that hertz. And if you were to keep it at that frequency and you were to keep it a very, very high amount of energy with your settings, essentially you are literally holding a lightsaber and you can't control it because it's too fast for the human eyes to accommodate. Regardless of what that happens, hasn't stopped them from pushing it out, and we have really begun moving away from holmium-based system to thulium because it's a lot more smaller. It goes faster. Yes, the hertz and the frequency can go up to 400 in this case, but as long as you don't hit it that amount, you could actually control very finely the kind of settings that you like. And so there has been a general shift from thulium-based laser to holmium-based laser. This is one of the last slides that I have. I was actually fortunate enough to be involved in the procurement process for another private hospital during my time in Sydney, Australia last year. And essentially, I was fortunate enough to actually have a go at all major brands of holmium and thulium platforms. So, and I actually get to compare them side by side. And as you can see, there were some benefits when it comes to the thulium fibers, and the only drawback is they are not as well researched when you use thulium fibers to do enucleation of prostate. Whole lab is a term that you may or may not have heard. Essentially, what that means is using holmium lasers to do a enucleation of the prostate. Therefore, it's called HOLEP, holmium enucleation of prostate, whole lab. Thulium, THULEP, is the next new kid in town. Lots of papers are coming out, and in terms of the efficacy and the role of thulium in reducing prostate volume. And naturally, this, I assure you, is something that's going to crowd the research space in the next few years. Now, with that, I come to the end of my talk today. I hope it has been not as boring as I'm afraid it will be. Now, just a shameless plug on myself. I do actually have a website that talks about a lot of common urological issues that I find myself repeating so often in clinic. So what I did, I just basically record everything down so that they can actually go back to look at it in case they forget. Most importantly, if their children doesn't come along, I direct them to these videos so that they can actually have an idea of what their patients, their family, especially their parents, are going through. And where possible, if I can get permission, I will post today's lecture and the slides up there as well. With that, I come to the end of my talk, and I'm happy to get any questions if there are any. Thank you very much.